Jackie. Okay. Today we'll be looking at community review, and the community review is us generally trying to see, as a community, you all worked in clinics, you all worked in hospitals, and now you're working in the community. What does it mean or signify for you to be identified as a community nurse? Apparently, these two is not working. Okay, which we are going to start with number one, defining community nursing. Jan, can you please read?
Community nursing involves the delivery of nursing care in the community setting, focusing on promoting health, preventing illness, and providing care in homes, schools, and workplace.
Exactly. So when we are talking about community nursing, those that are working in the homes, in patients' home, those that are working in schools, and those that are working in the workplace like industrial site, roads, or industries are referred to as community nurses. And here we are looking at promptly intervening in case of accidents. We are looking at promoting health if you happen to take care of maybe say a pregnant woman. We're equally taking care of an already sick patient, but then looking forward to seeing how they can live a more healthier life. We can talk about preventing illnesses. If say you are taking care of a baby and you need to make sure the child is completely fine, and taking care of palliative care or care for adults, you will be one of the individuals that is caring for a patient with special attention as a community nurse. Please, are you on live? Are you all on live? Next, in Qatar, community nurses plays a crucial role in health delivery and ensuring that the access to primary health and public health initiative are supported, especially when it comes to chronic disease condition. Most of our patients are going to be patients that are suffering from chronic disease condition. Out of those that will be caring for children with special needs, out of maternity nurses who will be caring for postnatal or prenatal care for pregnant women. If not, we all that are adult nurses will be caring for critically ill patients, because these are patients that have already been admitted in the hospital for a couple of times and are unable to handle the medication processing and different medical procedures that have to be done at home, and as well cannot take too long in the hospital. Is that understood? Next, overview of healthcare systems in Qatar. We have the MOPH, which is where we are supposed to be licensed, and as we know, to work under PNS or HMC, you need to be a licensed practitioner. We are equally going to be focusing on what? Universal access to quality care and health promotion. Most often, we are going to be having a problem if the quality of care that is being rendered by a nurse does not reflect what we should be. For the fact that you are caring for a patient at home does not mean that you are not going to be following every standards that you should have if you were in the hospital. Because documentations have to be complete and correctly done. Medication has to be given on time as though you were in the hospital. Vitals assessment and every other aspect of care will be respected. And again, understand that you are the only individual that is with the patient. Unlike other situations where there is Unlike in other situations where there will be all the care team, we have the nurses, different nurses, we have the supervisors that are with you, we have the doctors, we have the specialists that are with you. And if in that situation, if you are in the hospital, you know that care is readily available. In case there is a call for code blue, everybody will be present, right? But if you are at home and there is a call for code blue, who is doing the call? You. Who is intervening? You. Who is referring? You. There's no other person. And that is why you need to be one step ahead of the team or of an ordinary nurse or a normal nurse that is working in the hospital. And that is why you need to go through all this training to make sure that you are prepared and you are equipped to be able to manage and handle the patient at home without the assistance, without the supervision, without the intervention of any other person. It is only you and you alone. We are going to go to the next. Community nursing, please read.
Community nurses are key players in promoting health, preventing diseases, managing chronic conditions, and improving the overall quality of life.
One, we are promoting health, we are preventing diseases, we are managing chronic conditions, and we are improving the overall quality of health. So, you are not going to only be managing if you were in the hospital. Most often, we are based at managing chronic disease conditions because, of course, until somebody is sick, the person will not come to the hospital. True. Now, we already have specialty centers that are helping in what? Rehabilitating. We already have specialty centers that will be preventing. In case there is any need for vaccines or all, there will be another specialty center. But now all of these things have been put in you to take care of your patient, to be the only source of a health unit, a point of contact to the hospital and to everything in making sure everything goes right would be you. Next, PNS in Qatar also focuses on the outreach programs, which is the home health services, maternity, child health, and management of non-communicable diseases like diabetes and hypertension. I submitted to you the work for yesterday. You're complete with it? Still going through. You should go through it because you are going to go through a lot of that. So make sure that you finish one promptly. We go through it, then we take the next case scenario. Okay? Next, we have talked about promoting health. This will include you talking about health education. This will be you talking about lifestyles. This will be you talking about dieting. This will be you talking about exercises. This will be you trying to make sure that your hand hygiene is respected. Every moment of hand hygiene is respected. Just trying to make sure that you do not cause any infection or harm to the patient. Treating chronic disease management. Chronic disease management here will be you doing what? Wound dressing for diabetic foods. Will be you giving medication for the patient depending on the disease condition with understanding of the side effects of each medication. Will be you making sure that what? That mama, because she is dementia, I will be introducing myself without necessarily being asked or mama being frightened out. Who are you this morning? You just come in, mama, I'm Aisha, I'm your nurse for today. How are you? Though you told her the same thing yesterday, it's not guaranteed that she will remember you today. Is that true? Because she cannot even remember her own name. She cannot remember her children. She cannot remember her husband. He cannot remember the wife. You think he is going to remember you? So you just actively go back again trying to educate. This is you educating the family on the disease condition that the patient is suffering from and how best this disease condition can be managed. We'll be going to talk about what? We have provide health education on nutrition, on exercise, lifestyle, cessation of smoking for those that are smokers. Okay? For those that are obese, you need to see how they cut their diet, and you need to see how they get incorporated in exercises. It's not going to be an easy journey, but as long as you take one step at a time, you will get there. Community nurses help in managing chronic conditions, diabetes, obesity, hypertension, monitoring of vital signs. We have maternity and child care. We don't have any maternity nurse in here for the moment. We have adult nurses. All of us now are adult nurses, except for child care. No, she is already twisting her face. You take it easy, okay? I cannot joke with you. Remember that Janet too is a pediatric nurse. But Mom Patricia will come to take you all on pediatric nursing. Now, when we talk about pediatric nurse, you either be taking care of a child with special needs, or you just be caring for a mother that is just out from delivery, postnatal or postpartum care. And this is you helping to see and care for the child, schedule for a vaccination, making sure that the vaccination calendar is completely respected, make sure that you assess the baby for any deformities and try to see how these deformities can be managed promptly. Okay? But you are going to take the full course with Mom Patricia. Before you set me aside, for us who are adult care nurses, most often we are focusing on our management of chronic disease condition, which is virtually what every one of us is going to do. Management of chronic disease condition or palliative care. We hardly have a healthy adult that is in need of a nurse. Now, we are not just going to do this by ourselves. We are going to do this in collaborations with other healthcare team. Number one, you are going to be working with direct collaboration with me, because I will be working with direct collaboration with PNS. Now, in case where you need something and you do not know where to go from there, you get back to me. If I can direct you, I will direct you. But in case I am equally short on the possibilities of the solutions that you are, of the solution to the problem that you're facing, I will go to PNS and I will write them. They will tell us what next to do. In collaborations with the doctors of HMCS, in case our patient is under home health care. So if the patient has something emergency, you need one specific or one particular thing, medication prescription, medication that is in the patient's home, but not on your medication list, and you need it to be inclusive, we are going to call the home health care doctor, and he is going to include that medication in our medication list. Or there is a new complaint, the patient is now having a back ulcer, the patient is having a broken skin, and we need the home wound care nurse, we are going to call the wound care nurse to come to assist. In case the patient needs physiotherapy, we are going to get to the physiotherapist to make sure that this is included. If the patient is obese and we need to get a dietitian to come and see into it, that we'll get a meal plan for this patient, we'll get a dietitian to come and attend to the patient. So we are not working alone. We are working with a team of specialties, a team of different nurses, a team. If you need to do a catheter change, you are not to do a catheter change at home. You call a urologist specialty to send and get that catheter change done. Is that understood? So you should not be afraid. The journey ahead is cumbersome, but we can get it. Now these are my details. You must not bother about the other details, but here you have my email in case you want to send a formal email for a sick leave, for a complaint, or maybe you want to say something that you need to be taken to the administration. You can send me an official email. And here, this is my personal number, please, you send through the office number. Okay? Now we go to the next. To communicate with the administrator, please send an email to me and I will talk to them. If you want to communicate with Mom Patricia, you send an email to me, or you call me, or you just text me, please, Mom, can you call? I'll call you. Okay? You don't have to bother to the fact that I don't have the call credit, so there's no way I can call. Just tell me, Mom, please call me, and I'll call you. If you want to leave me a text, you can leave a text. But be rest assured that whatever the problem might be, I will see into it that we can give possible solutions to that problem. Okay? With the family, you are equally supposed to collaborate with the family. Now, this is their patient you're caring for. This is their loved one that you're caring for. They don't just want to dash you the patient and allow you to care for the patient by yourself. No. You are to care for this patient in collaboration with them. They are supposed to be inclusive in the care that you give to the patient. On the very first day, we are going to ask the patient, what exactly do you have as a goal? We are equally going to ask the family, what is the goal you have for your patient? They will tell you we want our patient to be able to walk. They will tell you we want our patient to be able to breathe normally. They will tell you that we want our patient to be able to get their blood sugar level normalized. You are going to include this, and within time, you are going to be giving them updates on how the patient is progressing since they were in your care. Is that understood? You don't just keep them out. They need to know, especially if the family is not living with you, if the family is not living with the patient. Now you go and meet patients or mothers that are living in their own accommodation, but their children have long gotten married and are living in their own separate homes. So they might come time to time again to check on this loved one of theirs, be it their mother or their father. Please always make sure that the person who is the decision maker have an update on what is happening with you and the family and the mother in the patient's home. Is that understood? Okay. Now, hours of service. Again, this is the hours of service that is given to us by parents. Number one, we have a 12 or a 24/7 service. What does this mean? It means that the primary nurse is going to work for the patient 24 hours for 7 days. Now, how many primary nurses will be working in this service? 2. And either 1 or 2 relievers. Now, 2 primary nurses will be working, 1 will be working morning shift, and the other will be working a night shift. And on the day that they are off, it is either going to be a Friday or a Saturday. If you have 1 reliever, it means the reliever will relieve 1 person on Friday and relieve the second person on Saturday. If you have 2 relievers, the 2 relievers will relieve the both of you on the same day. Is that understood? And now for somebody that is having a 24/7 service, you can easily swap positions. That means this month you are working morning and she's working night. The next month I will change and she will be working night and the other person will be working morning. Is that understood? This will equally go to people that will be doing a 24/6 service. For a 24/6 service, there will be 2 primary nurses, no reliever. And they will be off on the same day, or they will be off on separate days, depending on how the family wants it. Now, if the 2 of you will be off on Friday you're off. It means one particular day has been dedicated by the family to be the one to care for that patient. Is that understood? For these 2 primary nurses, I am equally able to swap your positions at the end of each month. So this month you are working morning and the next month you are working night, and then I change the following month. Now this is where the real problem comes. When you are working a 12/7 service, what a 12/7 service implies is that you'll be working for 12 hours for 7 days. The primary nurse who is working here will work 12 hours for 6 days, and there will be a 1 reliever who will relieve that primary nurse on her day off or on his day off. Is that understood? Now, if you are working a 12 on 7 or a 12 on 6 service, and the family has decided that you'll be working only mornings, you are going to work only mornings until the day that service stops, until the day the family decides to change you to night. Not me, not PNS. Is that understood? If you are working night, you are going to be working night duty until the day the family decides that you should be working now morning. I cannot change it, PNS cannot change it. This is family decision. If the family decides that your off will be Saturday, your off would be Saturday until they decide to put you on a Friday off. I cannot change it. PNS cannot equally change it. Is that understood? So I know, and I am telling you now, because you will start working, and then you get to a moment where you will be tired, you will be exhausted for a particular shift. I am tired of getting up in the morning at 5 because my shift starts at 6. I am tired of getting up I am tired of working in the night, I want to work by morning. I am sorry, as much as I sympathize with you, there is nothing I can do. Is that understood? So one thing I need your mind to be prepared from today is the fact that if you're a night duty nurse, because your patient is on one of these services, please let your day be your night. When you come back from work, make sure you sleep adequately. And you can go in the night and be productive as much as you can. If you are a permanent morning duty nurse and probably you are starting duty as early as 6, please bear with me that your mornings ends or your night ends as of 4 o'clock. That is 4 a.m. in the morning. Is that understood? Please and please again, these are the services. If you are fortunate to be on a 24 on 6 or a 24 on 7, good for you. I can be able to, ma'am, I don't want, of course, I will definitely keep changing you guys per month, just so that one person rests and the next person take the other shift, the next person rests and the next person take the other shift. But if you are alone, there is nothing I can do. I just can only create an environment that will permit you to sleep well in the night, or create an environment that will permit you to sleep well by day. Is that understood? Okay. With that so being understood, this is the same explanation that I am giving. Now, before we get to the level where we will be sent, I have spoken about this level, okay? Before we get to the level where we'll be sent to care for our patients, the first thing we need to cross, the first bridge we need to go through will be passing the competency. And the competency is based on the 5 core competency subjects, which is what? You just come in, number 1, senior nurses.
Physical assessment.
Physical assessment will be one of the key to you passing your competency. And now we are not just looking at only physical assessment. We are looking at assessment in a whole, from ABC, from physical assessment to vitals and everything that has to do with assessment as a whole. Number 2, what?
Pain management and reassessment.
Pain assessment, management, and reassessment. You must be capable to assess your patient's pain. 1, you must be capable to manage the pain depending on the level. And 2, you must be able to reassess that patient's pain and determine what to do next if the pain is resolved or if the pain is not resolved. Is that understood? You can go out and get some cool water to drink. This is going to help you. Why? What? You do not sleep well in the night?
No.
So why are you sleeping?
Just to leave now.
Okay. Get some water. If you want to take some cup of tea, take a cup of tea and see that you are okay. Is that understood? So we are going to be looking at pain, and we are going to be looking at pain indicators. Which pain scale are you going to use with regards to the patient that will be given to you? With regards to the patient that you have. If your patient is suffering from dementia, how are you going to assess the patient's pain? If your patient is unresponsive, how are you going to assess the patient's pain? If your patient can speak, how are you going to assess the patient's pain? So these tools are going to help you to know what best to do, when, and how. Next, we are going to be looking at communication with the use of ISPA. Now you are going to be having the form. You are going to be having the form in which you are going to use to present your patient so that you understand what it is and what you are supposed to put on the ISBA form. Is that understood? With regards to the case scenario that I gave you yesterday, I'm going to print this form and I will equally give you to work with it. Okay? Now, I did not give the two of you. Remember, you're senior nurses. You are just going to attend to my class, and then you attend to revolving on the PMIs, and then you'll be good to go. Okay? They are new nurses. You already gone through the PNS system, and you know all these things. So you are just here for a revision, and especially for me, because we are talking about the company policies and how everything is going to be. So communication by ISBA, this is you, one, how to report. If something happens and you need to call the hospital, what steps do you do to report the whole scenario? Presenting yourself, presenting the patient, presenting the diagnosis, presenting the medication taken, presenting the vitals at that moment, presenting the scenario, what happened, your inspection, your interventions, your evaluations, and the reason why you need more assistance, and the reason why you need to send the patient to the hospital. Now, without you taking all these steps, now I have said it, it looks so easy. But when you are given, you realize that it's not as easy as it looks. Okay? These steps must be respected, and these are the key that will enable you to get quick access to the hospital, to get quick access to the ambulance. Because if you are unable to communicate what is happening with you and the patient at that moment, there is nothing anybody will tell you. What will be your response? Please, ma'am, assess your patient and get back to us. Now you are with a patient that is probably at the verge of dying, but you still are sent to go back and reassess. This is something you would have done before doing the call. You need to tell them what you did if it is a situation where you can manage. And you need to equally tell them that after the intervention, and okay, come on. After your interventions and everything done, you still was unable to bring down the temperature, to bring down the sugar level, to raise the sugar level, to bring down the blood pressure, to rise the blood pressure. The conscious level is going and it's getting to 5, it's getting to 4, and this, you must tell them what you did, and after which your assessment did not help. Is that understood? And if you need a doctor, if you need a prescription, if you need an ambulance. So you are going to go through ISBA. Number 2, you are equally going to use ISBA to do your reports. First, your daily report, when you are about to go for a shadow, you are going to understand and you're going to have a broad lecture with me on your daily reporting. Your communication for daily report will equally be using the ISBA tool. Next, when you are doing your care plan, your care notes, your nursing progress note, you are equally going to use the ISBA tool in communication. Is that understood? Okay, next we will be looking at infection control. Infection control, we are going to be looking at moments of hand hygiene. Can I get some of the moments of hand hygiene? How How many moments are there for hand hygiene? Start with you.
Before touching the patient.
Before touching the patient, yes.
Before aseptic procedure.
Before any aseptic procedure, yes.
After touching the patient.
After touching the patient.
After exposure to blood or body fluid.
After exposure to blood or bodily fluids, yes.
After touching the patient's surroundings.
After touching the patient's surroundings. These are the moments of hand hygiene that should be respected at all moments. At all moments. You don't do it when you are seen or watched or observed or supervised by anybody. These are moments that should be incorporated in you, that at every moment, because I touch bodily fluid, I should get a proper hand hygiene. How many minutes are you supposed to? How many seconds or minutes are you supposed to do your hand hygiene?
40 to 60.
42 to 60. Now, what are the steps? How many steps of hand hygiene? When you are doing hand washing, how many steps are there? 7 steps. Martina is going to give you in depth of hand hygiene, the steps, the moment we even have a dance, that we all will definitely come into join and do the dance. Is that okay? So these are some of the procedures or the steps that you're going to do to prevent infection and to help to control infection. Now, which other PPEs or what are the PPEs that you will use when handling or caring for a patient?
Gloves.
Gloves, yes. A face mask, a gown, goggles. What did you say? A face shield. Okay. Now these two are equally going to help you to prevent being infected and to prevent infecting others. Is that understood? Okay. Now when we leave from infection control, we go to medication administration and management. Now when you hear medication management, no, let's start with, when you hear about medication administration, what are they talking about?
Rights.
We have rights of medication administration. How many rights are there? 10 rights. Let's start with you.
Right the patient.
We have right patient, yes.
Right dose.
We have right dose, yes.
Right drug.
We have right drug, yes.
Right route.
We have right route, yes.
Right documentation.
We have right documentation, which should be coming after all the other rights have been observed. We have right to refuse. And that is why when you start administering medication, you will realize that some of your patients will refuse to take their medication. Does it mean that you allow them and the medication to go away? No, you're going to convince them and convince them and convince them it is the only right that even though we want to respect it, at some point we still don't want to respect it. Okay? Because given to some patients, they are never going to accept to take their medication. You think that caring for a baby will always want to take his or her medication? It's going to be a fight. World War III. Every medication is going to be a fight. Do we respect the fact that the baby does not want to take medication? No. We're not going to respect that, Habibi. We know that this is one of your rights, but we just have to find our way to make you take it. Okay? And again, we have other patients that with refusal, we might compromise. But what do we do to respect this right of refusal? If the patient is taking insulin, that is a high alert medication, right? Do we approve the right for refusal? No. Now, if the patient still refuses to take the medication, what do we do? Right for education, yes, you have educated the patient, you have made sure that they understood the effect, the side effect, the consequences of not taking their insulin. They still refuse. What will you do?
Sign the refuse form.
Sign the refuse form. Now, you give them a consent form to say, I am giving my consent and I said, I don't want to take the medication, right? What will you do next?
Inform the family.
You inform the family, you inform your nurse supervisor, and we open an over. Now, if a patient refuses to take a medication that is PMR, it's okay. If a patient refuses to take a medication, a PRN medication is no problem that a patient refuses to take a PRN medication. Now say it is a paracetamol, it's a multivitamin, and the patient says, I don't want to take. Or maybe say it's nebulization and the patient is breathing fine, oxygen saturation 95, 96, 98. Is it a problem? No problem. Is there a need for an over? No. Is there a need for a consent? No. Why? Because the medication cannot put a patient in harm's way. Refusal of that medication will not cause any harm to the patient. But if this patient is hypoglycemia and you want to help the patient by giving sugar per se, and the patient tells you, no, I don't want, you need to do something. One way, it is either you're going to open them over, you're going to make sure, educate the patient in. If all of that, the patient still refuses, you need to open an over. And an over is going to be sent to PNS to inform them of the fact that their patient has refused to take medication. I think I have. Yes, PNS? Hello, ma'am. This is Aisha. I still have all this. Okay, let's finish this during break. I will go to the floor after that. Is that understood? Now, we have the right to refuse. Yes, let's continue. This was the fifth or the sixth? The fifth. Yes, another right.
Right to education.
Right to education. She said right documentation is something else. We already had that. Yes, said already.
Right to assessment.
Yes, right to assessment. Yes, that can go. That can go, right? Evaluation can go. You have your flip card with you, they should have the table.
Life pension.
We already spoke, the first person said right patient. Now, when you are looking at medication administration, what are you looking at after the rights?
Assess for any allergic.
We assess first, we assess for allergies, there is no allergy. After that, what do we do? Documentation is under the rights. After we have assessed for allergy, what are we going to do? We review the medication, you can review them as much as we are talking about expiring date, review date, all this that can still be under the rights. Right identification can still be under the rights. Right medication administration. Now, what are we supposed to do?
Inform the patient.
About?
The medication that you will give to.
Yes, consent. Right for consent. We could still put that under the rights. What are we supposed to do? Before you administer high iron medication, what are you supposed to do? Double check what? We've checked that already. What else? We check the vital signs. Checking and monitoring of vital signs is part of the medication rules that you need to do before you administer a medication, especially if that medication is a high alert medication. One, after you have checked the vital signs and you need to administer the medication, what do you do now?
Explain to the patient.
Minus explain, you go back to, you come back now to administering the medication itself. Now, after you have administered the medication, now medication management, what are we looking at? Yes, medication management, you go back again to hand hygiene if you want. And then what else? What? Say it. Medication management, what are we going to be looking at?
Side effects.
We will still be evaluating the effect of that medication. If it is good, if it is not good, if there is an adverse reaction to the medication, if there is an allergic reaction to the medication, we will still check our vitals to make sure that we have achieved the purpose for which the medication was administered. Reassessment. Most often you are going to respect all the 5 core competencies. At the end of it, you are not going to reassess. And you are going to fail. Just reassessment. No matter what you do, no matter how you do it, you should be able to reassess the patient to make sure that what? That the patient is okay. That what you have done have helped the patient in one way or the other. Or what you have done is causing harm to the patient, because if you early identify, it helps you to do what? To early intervene and hence save the patient's life. Is that understood? So these are the 5 core competencies that you are going to be working with. Take great note of it. Madam Patricia is going to be taking each and every one of these. Now, with the 5 core competency which you are going to be working with, for all those that did interviews, you were told you have 2 chances to pass. If you fail the first time, you'll be given another chance to take it again. Now, if you fail the second time, you will be out of the program. Now, you will be going to the management, and the management will decide what to do with you. But after the second trial and you still fail, you cannot work for PNS. Before you work for PNS, you must pass your competency. Is that understood? Next, if you pass the first time, you'll be given a patient, as well as if you pass the second time, you'll be given a patient. Now we are looking at the components that will help you to be that goodness that we want you to be. To be, nobody is perfect, but we are all a work in progress. We work every day to make sure that we improve who we are from who we were yesterday. And the first thing when it comes to nursing is confidentiality. On no occasion or the other should we come and you are inside the nurse's accommodation talking about your patient. No. As long as someone has no relationship to what you are facing with the patient, you have no right whatsoever to sit in the accommodation and you are talking about your patient. You talk about your patient with those that are directly involved in the care of that patient. You can talk about your patient with the children. You can talk about the patient with the care partner who is with you. You can talk about the patient with your colleague with whom you both are sharing that service. You can talk about your patient with me, or you call and talk about your patient with the hospital. But you don't talk about your patient in the car. You don't talk about your patient in the hallway. You don't talk about your patient in the laundry. You don't talk about your patient in the lift. Because then you will receive, some of you might receive a patient that in that same house, the other family members do not know what is wrong with that patient. That is how much confidential they want their disease condition to be. Is that understood? And imagine you going to the kitchen to take food and you are talking about the patient with the maid or with the cook. How do you think that is going to lead you? You are going to come back, shift one way to the accommodation and the same to go because you breach confidentiality. Is that understood? Now, for key principles, number one, you have to respect patient's autonomy. You must be able to allow the patient to give decisions that involve their own health. I want this or I want that. Give the patient the decision to take when it comes to their health. If you want to give medication to mama, tell mama, please, it's 8 o'clock, I need to give your medication. She will approve. If she refuses, educate her. If she still refuses, give her 5 minutes, come back and reinitiate the patient. If she still refuses, re-educate her. If she refuses, go call the care partner to come and talk. If she refuses, call the daughter to whom she pays her respect to, and until she accepts. Is that understood? If you want to give mama a bath, it is 11. Ask mama, it's 11 o'clock. Do you want to have your bath now? If she says no, I want to bathe by 3, 3 it is. Is that understood? You don't force them, you only make them do the things that they are supposed to do in the time that they want it to be done. Except it is a medication. If you want to give her food, tell her, Mom, dinner is ready, lunch is ready, breakfast is ready. Do you want to take it now? If she says, give me 5 minutes, give her 5 minutes. Is that understood? Let her be involved. Let her be the one to take the decisions on the things that are going to be done. Because she will feel good about doing it. Now, I'm talking about adults, okay? I'm not talking about babies. I'm talking about people who has the well knowledge to understand, refuse, and accept. I'm not talking about people who do not know what is right or what is wrong. As long it's time to feed a baby, it's time to feed a baby. At all moments, they will either want to eat, or at all moments, they will not want to eat. Okay, these are babies after all. So you will know how to pick them, to nurture them, to play with them, to get the whole place either in music, or you become a singer, or you become a dancer to make sure that your baby eats. But the goal is that the baby should eat. If it is medication, they are going to cry, they are going to curse you, they are going to say everything that is good plus the ones that are not good. Of course, you should not take any of those things to heart. These are just children, or these are just people that are in pain. Is that understood? Next, professional and ethical obligations. You have to respect all professional and ethical obligations. Please do not act or do something simply because the decision maker is around. Do not act or do something because you are being watched. First off, in every home that you will go, there will be a camera. Know that when you can see it or you cannot see it, there is a camera in that patient's room. It is not so that they can monitor if you are doing your job or not, because of course, if you are doing your job, you don't bother who is monitoring you or who is not monitoring you. All right? But I want you to know that they have their eyes on you and you should be able to do your job and do your job correctly at all moments. Especially for the night nurses. Your patient's home is not where you go and have a good night rest. You are on duty, and duty you should be doing. You are supposed to sleep by day and work by night. Not come back from duty and you are in the accommodation dancing, you are in the accommodation making noise, then when it's duty time you are tired. No. By day you should be sleeping and by night you should be working. You don't go to duty to sleep. Even if the family tells you you can sleep, tell them it's my duty to be awake to care for my patient. Is this understood? Next, need to know basics. You should understand your patient's condition for each and every one of it. Because there might be patient with 5 different diagnoses. There might be patient with 7 different diagnoses. You should understand each one of those diagnoses and how they relate with each other. You should understand the medications that you are administering to the patient, how it helps them, and what will happen if you give an overdose, and what will happen if one of these medications goes wrong. Is that understood? You should know your patient and know how to care for them. At least know the basics. You should know the goals, the long-term goal, the short-term goal, and each day you should have a care plan that you want to use to care to your patient. Are we together? Okay. Consent, I have already said it and I will say it again. At every moment, make sure you take consent from the family, from the patient, to do anything they should approve. If they cannot approve, educate them if it is very necessary. If they still refuse, if it is something that does not or cannot put them into harm's way, let it be. If it is something that will put them in harm's way, educate them and get other people involved into it. Now, if the patient tells you today that I don't want to bake, what will you do? The patient says, I don't want to bake today. Respect. Respect the fact that she said today she does not feel like getting water on her body. But tomorrow, and in your nurse's note, I should see during where you were supposed to bake the patient, that patient preferred not to shower today. And the next day, I should see you convincing the patient to tell them how good it will feel if they actually take a shower on the second day. Now, not bathing for one day will probably not kill the patient, right? But now, if it does not bathe for 1 week, it will harm the patient, right? So you will know the second day, I will now try to help the patient, to educate the patient, to see reasons why they should bathe. And even if they don't want to bathe, at least I should give them a towel back on the bed, right? You should know how to speak to your patient. Best practice. The first thing you should know when we are looking at a nurse and how good the practices are is the fact that you know how to handle your medication records. These are vital documents of that patient with which they might not want someone to see. So the patient's medication record must be put in a secured, locked cupboard. Is that understood? That can only be accessible by you, by the patient, or by the decision maker. Two, avoid unauthorized disclosure. I already said it. Do not go to the elevator and you're talking about your patient or their condition. Do not go to the hallway and you are discussing about the patient and their condition. Neither should you hand over in the presence of visitors. If there are visitors that came to visit and it is your time over and you need to hand over, you can simply ask them, please ma'am, please Baba, give us 2 minutes, you go hand over and then you can come back in when we are done. But doing handover in front of visitors is completely wrong. Is that understood? Okay. Now, when we look at professional communication is the way you speak. You can hear me, right? I'm sure even Sylvain in his office, he can hear me. I'm sure if I call Martina now, she'll tell me she can hear me. Is this how you are going to speak in the patient's home? No. You are going to speak in a low tonation that is going to be audible enough to the person you are trying to hand over to. It should be in the confinement of that room and to the understanding of you, your care partner, or the next primary nurse that is taking over shift, and the patient. Is that understood? Not loud. Nobody out of that room should be able to hear what you are saying. Neither should you be now speaking in such a way that the primary nurse cannot hear what you are saying. Is that understood? Patient's privacy. You should maintain patient's privacy at all moments. On no account should I go on social media and meet you and your patient doing TikTok. It should never happen. On no account should I meet you on TikTok with your uniform. It should never happen. Am I saying that you cannot educate on social media? You can. Am I saying that you cannot own a social media platform? Of course you can. But you can do so without putting on your uniform, and you cannot do that in the patient's home. When you get home, you can do it. Is that understood? You must maintain patient's privacy at all moments. That is from bathing to documentation to medication and everything that has to concern the patient. Okay? Consequences of breach. Now we know that for any parliament, if you don't do what is right, they are going to set you to the right path. The same as every organization, the same as every institution. Even in your homes, you're married, you have kids, not yet. Okay, anyone has kids here? How many children do you have, lovely? One. Okay, I do have one beautiful daughter, okay? Now, if you ask your daughter not to touch fire, and she decides, after you have lit a candle, she decides to go touch it, will there be consequences or not? There will be consequences. Now, to some of us that we are married already, please single, don't die, just keep breathing. If your husband asks you not to leave the house and you leave, what will happen? There will be consequences. You will come meeting a tiger waiting for you to chew, even though they can't chew you. So for everything that is right, there is a chance that if you not respect those right things, there will be consequences. So if I call you at any moment to tell you this and this and this is wrong, that is either because your care partner has given those reports, or that is because something happened that you are not doing correctly. Is this to kill you? No. Is this as a way of punishing you? No. This is just to make sure that you desist from doing the wrong thing and do the right thing. Because we are nurses. We are not saloonists. We are not fashion designers. Then you make an error, then you buy another material, you come and redo it again. If you make an error, it might cost a patient's life. And that is something you cannot give again. Is that understood? So, number one, for disciplinary actions, you can either get an employee sanction, that will be you having a warning letter and all that, or you might lose your license if in case you actually did something that hurts the patient badly, or you might, if you lose your license, of course, you might be terminated. But you can be terminated without losing your license. Let's say that you go to duty 2 or 3 times drunk. You were on duty smelling alcohol and drunk and was unable, oriented enough to care for yourself, talk less of caring for the patient. That is a zero tolerance act. If you do that one time, you sure will have a termination. Because of course, it would rather save you and save the patient, rather than allow you go kill yourself and kill the patient alongside. Is that understood? Next, legal penalties. You can get a fine, you can get a lawsuit by the family. Imagine you come to duty drunk and you administer insulin 5 times. Do you know where by the time you gain consciousness that patient will be? The patient will be meeting the Lord. Because you will not have the knowledge, the consciousness of checking, of assessing, to make sure that this patient is taken to the hospital when it's bad. Neither will you have the consciousness to practice the right by doing medication check, evaluation, and monitoring. So you will kill the patient. And you think if you kill the patient, what will happen to you? You will be charged for felony. That will take you 10 years to a lifetime in prison. We don't need to terminate you. We don't need to give you a sanction. You don't need to lose a license. You've lost your whole life. Is that understood? We are not just trying to do the right thing. We are trying to do the right thing as well as stay away from jail. Because when we do the wrong thing, the only place where we are looking at is jail. Is that understood? Okay. Loss of trust. Now you might lose the trust that the patient has for you if they realize that you do not understand or has any background knowledge on what you are supposed to do as a nurse. Imagine that you have somebody caring for your mother. She has diabetes, and then you come in and ask the patient, this diabetes of a diagnosis that was given to my mom, what is it talking about? And then the nurse start making what do you think the family will be looking at you? So be like, where did they bring this one from? Are you sure you're a nurse? That would be the questions that you get. And then she comes back the next day and we're like, the insulin that they were supposed to administer to mama, what is the unit? You don't know. You are the one, and that nurse is working with your mother. Will you keep the nurse there? Will you allow the nurse to keep working for your mother? You will not. Now, let's not look at the reaction of the family and make it be like it is going to be something so big. Now, put it to yourself. If your mother was sick and you went, paid for a nurse and brought to your mother to care for your mother, and she does not know the basics of what your mother is suffering from, or how to give medication, or what are the units of the medication the mother is supposed to take, will you allow that nurse to be the person to care for your mother? No, you are not going to care for my mother. You need to go back to school. None of my business. Okay, now I already spoke about the CCTV cameras that are always in the patient's home. Now, referral, I have given you the communication pathway when it comes to ISBA. And ISBA is going to help you refer your patient step by step. In a situation where there is a crisis, patients start losing consciousness, you cannot manage. During a morning handover, you assess the patient and you realize that the patient is suffering from a pulmonary edema. It's an emergency, you need to send the patient to the hospital. So one, assess the need for referral. As so long as you think that that situation needs you to refer, you should assess the patient and identify exactly what the referral is all about. Number two, identify the reason. Now, I came into the patient's room and I met the patient on the floor, unresponsive. I don't know what happened. I should identify the reason for referral. This is what happened. Or maybe I met the patient is responsive, but not coherent. Okay? Next, we are looking at need for specialized care or diagnosis. Is the patient in need of a specialized care? I realize that there is a fracture. Can I care for a fracture from home? No. I need to send the patient to the hospital. They need to check. They need to do an x-ray. From the x-ray, they will know if the fracture is what needs to be, what the patient needs to go in for surgery, right? Now, the patient is having breathing difficulties and are not having oxygen in the house. I check the oxygen saturation and the patient is 86 or 85. Do I keep the patient at home? I need to send the patient to the hospital. Inability to manage the patient's condition with available resources. Now, the resources you have are not adequate enough to manage that patient at that moment. I need to send my patient to the hospital. If I cannot do it, somebody else should do it. And that is why I said the goodness starts from when you realize your limitations. You are the goodness when you understand that at this level, I cannot, my practice stops me here. This is supposed to be managed by somebody else. And you refer the patient to that person. The patient needs to undergo some chemotherapy. You send the patient to undergo chemotherapy. Can you do it? No. You go out, get some water to drink, get some tea to drink, then you come back. Okay. Emergency care equipment. You must make sure that at all moments you have emergency care equipment in the patient's home. Let's say that a patient is on a tracheostomy. You need to have 1 or 2 sets of sterile tracheostomy set at home beside the patient's bed. What if the patient gets up agitated and you remove it? Are you going to place it? No, you are not going to place it. It is only there so that if in case the emergency team is coming, they can start using what you already have. Is that understood? If your patient is on a catheter, you should have a sterile catheter set in your keeping. Is that understood? If for a catheter, they can do it at home. A tracheostomy, they might need to take the patient to the hospital to do it in the hospital because they want a sterile environment. If the patient comes and the catheter is out, the person will just come in, assess the patient, take the set that you have and go. They might bring their own set. They can use your set and give you a new one, or they can use their set and still keep your own. But your own should be with you at all moments. If the patient is on oxygen, there should always be a portable oxygen reserve kept. What happens if there's an emergency and we need to go to the hospital? Would they carry the long cylinder? Can they carry it? Can you take it? But if you have the portable one, when they come, they will use your portable cylinder and take the patient to the hospital. Is that understood? Okay. Now, with referral, you need to obtain all consent. You're either taking consent from the patient or you're taking consent from the family, who is the decision maker. Now, this is you explaining to them, we need to take the patient to the hospital because of this, and this. And this is the emergency, and if it's not acted upon, this can go wrong. And from that moment, this is going to be resolved. Is that understood? Okay. Equally for the baby nurses, if your baby If you identify that the baby has not stooled for 4 days, the baby has not stooled for 5 days, and you think there is a need to take the baby to the hospital, first, you need to identify which hospital you need to take the baby to. Second, to identify if the insurance of the baby can cover the medication and the services that will be offered. You need to make sure that if the insurance cannot cover, that the family can pay that by themselves. You need to try to get transportation. If it is going to be if they have to prepare for your transportation, or you need to call an ambulance. When you verify all these things, you now talk with the family, and from there, you take the patient to the hospital. Is that understood? If the patient is already under HMC, under which SIDRA, then you will just call the patient's physician, and then they will ask you to bring the patient to the hospital. Is that understood? But you need consent from the family or from the patient themselves. Identify the appropriate facility. I said this, you need to identify the facility. For children, you'll be taking them to SIDRA. For adults, you'll be taking them to HAMA. Prepare for transfer medication record. Each nurse going to a patient will have a medical record that will be prepared by me and handed to you for that particular patient. This medical record should always be prepared and safe, so that in case of an emergency, you pick the medical record and off to the hospital you will go. Next, you must be able to keep what? You must be able to compile the medication history treatment plan and the recent test, medication non-allergies for medication. When you are going, you will show them what you have been taking. You will show them any record of an allergy, so that they get known to, because they might be allergic to one medication, and that medication has a lot of other medications that have the same compound. Is that understood? So they get to avoid all that. Communicate with receiving facilities using ISBA. You communicate with the receiving facility using ISBA, and from there they will tell you the availability and what time you should come in. If it is an emergency, you'll be received in the emergency unit before you are sent to either the medical or the ICU. Is that understood? Coordinate transportation, I've spoken about that. Follow up. When you get to the follow-up addresses what? 1, follow up any additional concerns or questions. Make sure that before you take your patient from the hospital, you follow up if there is additional medication, if there are any changes, if there is additional appointment, anything that has been added new from that time period, you should check. Number 2, make sure that the reason for which you refer that patient was met. Are we together? You refer the patient because the patient has been losing consciousness. And then you go to the hospital, the patient is discharged, still unconscious. Was the reason met? So why are you taking the patient? Make sure the reason has been addressed and met. And again, it should no longer be a problem to the patient. If I the patient because I was suspecting pulmonary edema, and after assessment and everything, medication, the patient made 10 days in the hospital, if I'm taking the patient back home, I should be sure that this pulmonary edema was resolved. And it will not be a problem again if I go home and the patient starts having difficulties in breathing. Is that understood? Not just that, you will follow up now with me. You will give me the same appointment report through ISBA on what happened has been updated, so that I can go back to PNS and ask them to give you a new medication list. That will now have all the medication that has been added onto the medication list that you had before. And if there were any changes, we will see the changes on the new medication list. Is that understood? In the situation where the patient is admitted in the hospital, now, under PNS still, if the patient is admitted in the hospital in the medical ward, from day 1 to day 10, you will be home, or I will use you as a reliever for another patient. Most often you will be home. but those days are still considered by PNS. Now from day 11, PNS will hold your service with that patient and you'll be used as a reliever. If the patient is out of the hospital, the family will go back to PNS and they'll inform PNS about the fact that the patient is home. Or when the patient is about to be discharged, they'll go to PNS. PNS will get back to me and we will make you ready to go to the hospital to receive that patient and take the patient home. Because you need to take over from the hospital, handover will be done in the hospital, from there you go home with the patient. Is that understood? If the patient goes from home directly to the ICU, we will hold the services on the same day. Services hold. Whenever they get discharged from the ICU, we will take the procedures again. However, if this patient has been in the ICU for more than 3 months, they will start the PNS routine for approval all over again, and we will either give them a new nurse. If it is a VVVIP patient, we are not going to use that particular nurse until 3 months. If it is a regular patient, the nurse will be given to another patient, and when that patient is discharged, we will give them another nurse. Is that understood? Okay. Now, if you have a question, you can bring your question. If you have a doubt, I will clarify your doubts, and I will give you a short break to eat something, drink something, go to the washroom, relax, and I'll come back after I have done some work in my office. Any question? Any doubts? Any clarification? Anything different from what you already know?
Regarding the admission in the hospital, there are some instances that there are families that they want to continue.
With a particular nurse?
Yeah, and if the patient admitted, how many days until they hold
I said the service.
service?
Now, if the patient is admitted in the medical ward, it is up to 10 days.
10 days.
On day number 11, we will hold the service.
What if they want to continue in the hospital?
Now, we already explained this to the patient on the very day of starting service. That if you get admitted in a hospital, we will hold your service for this number of days. If you get admitted in the ICU, we will hold your service for this number of days. Now, if it is a VVIP that they do not want the nurse to be utilized, they will go to PNS, they will make their approval known, PNS will approve it, and then nurse will be kept for them. If it is just maybe a hypo or hyperglycemia issue contribute to an emergency unit, and the patient has to be there for say maximum 3 days, the nurse can be with the patient in the hospital, no problem. Or the nurse can be in the accommodation. If the patient wants the nurse to be with her, the nurse will be with her for maximum 3 days. After that, you need to come back, and then we'll start again from here. Is that understood? Any other question? All right, you go get something to eat, drink something, and reflection. For those that are sleeping, make sure you don't sit, be walking around so that sleep comes out of minutes. All right.